Good morning, everyone. I am Dr. Vinod. I'll be speaking today about the impact of the new criteria for cirrhotic cardiomyopathy and the future directions. This is the brief outline of my talk. Coming on to what is cirrhotic cardiomyopathy, its prevalence, and why it is important to investigate. Cirrhotic cardiomyopathy is basically defined as cardiac dysfunction in cirrhosis with no primary underlying cardiac disease. It has a typical pattern which is hyperdynamic circulation at rest with the blunted chronotropic response to the stress, and characterized by diastolic dysfunction and electrophysiological changes, namely QTc prolongation. And there is a modern concept of cardiohepatic axis, that is a bidirectional liver-heart interaction affecting the outcome, especially during the stress time. How to define cirrhotic cardiomyopathy? It is a cardiac dysfunction in patients with cirrhosis, which is characterized by blunted contractile responsiveness to stress, altered diastolic relaxation, that is a stiff heart, QTc prolongation, and absence of any other cardiac disease. It is often clinically silent at rest but unmarked during the hemodynamic stress, which can be sepsis, TRIPS, or transplant. So this basically shows the historical evolution of cirrhotic cardiomyopathy. Initially, it was reported by Kolsky et al. In 1953 as a hyperdynamic circulation, which is characterized by increased cardiac output and decrease in the systemic vascular resistance. Then we moved to the 2005 Montreal criteria, which relied heavily on the reduced LV ejection fraction and strength chronotropic competence. Then we have moved to 2019 CCM consortium criteria, which is the modern criteria, and which acknowledges the preserved liver ventricular ejection fraction but subtle systolic dysfunction, that is global longitudinal strain, and the advanced diastolic markers. And coming to the era of different phenotypes of CCM, namely ACLF, forward and backward failure, cardiohepatic axis, and the post-TIPS and the post-transplant outcome related to the cirrhotic cardiomyopathy. Why diagnosing the cardiomyopathy is important? This basically is a driver of the hepatorenal syndrome, and AKI has been reported to approximately 7 to 21% of the post-transplant death and death post-TIPS, and grade 3 diastolic dysfunction has been associated with a 2-year mortality of 40%. Coming on to the epidemiology, the reported prevalence rate widely ranges from 6 to 70% depending upon the cohort and the diagnostic criteria. New criteria often reduces the diastolic dysfunction. However, there is an increase in the prevalence with the systolic dysfunction, which is reported with the new criteria. The old criteria, the approximately prevalence ranges approximately 45 to 70%. And the standard diastolic dysfunction criteria on the American or the European Society, 30 to 40%. The CCM consortium criteria, the prevalence of the cirrhotic cardiomyopathy ranges from 25 to 55%, and only upon the strain imaging, that is global longitudinal strain, the prevalence increases up to 50%. The cirrhotic cardiomyopathy is often silent at rest and it decompensates under the stress. Cirrhotic cardiomyopathy can be seen in up to 1/3 to 1/2 of the patient with cirrhosis, and when there is stress, which can be in form of TIPS, sepsis, it is unmarked. It affects it increases the risk of heart failure, pulmonary edema, or perioperative or early post-transplant mortality and heart failure. It affects the renal perfusion associated with waitlist event and mortality. It limits the use and titration of non-selective beta blocker and the other vasoconstrictor, and has been a target for risk stratification. It's a potentially modifiable factor. Coming on to the pathophysiology, the various molecular mechanisms that have been reported. The first is desensitized heart, which is basically because of the beta adrenergic dysfunction. The hallmark of cirrhotic cardiomyopathy is the inability of the heart to increase the heart rate and contractility appropriately. There is a chronic sympathetic overactivity, there is downregulation of the beta receptor, and there is a uncoupling of the G protein, and which leads to impaired chronotropic and inotropic competence. There's alteration in the cholesterol phospholipid ratio in the cardiomyocyte membrane, leading to the increased rigidity of the cell. The dysfunction of the potassium channel, there's leading to the downregulation of the potassium channel, leading to delayed repolarization, impaired L-type calcium channel, reducing the intracellular calcium transit and weakening contraction. There's an increase in the cardiodepressant, namely nitric oxide, endocannabinoids, and cytokine, which are the target for the future drugs, which is reported in cirrhotic cardiomyopathy. This basically summarizes in a cirrhotic liver, this portal hypertension, there is increase in NO/CO, endocannabinoids, there is splanchnic vasodilatation, there is a reduction in the systemic vascular resistance, there is deformity of the titin and the upregulation of the alpha of the beta SC molecule, which promotes the myocardial fibrosis and the cellular defect, and basically it basically defines the pathophysiology of the cirrhotic cardiomyopathy. Coming on to the criteria, how we move from 2005 to 2019, that is the modern criteria. The old standard was dependent upon the systolic criteria, that is resting left ventricular ejection fraction of less than 55%, or blunted increase in the cardiac output, that is less than 10% on the stress test. However, the problem was it was load dependent and low systemic vascular resistance, and loads the heart, artificially boosting the left ventricular ejection fraction. And similarly, the diastolic criteria depend upon the E by A ratio, which is basically the early rapid ventricular refilling versus the late active contraction. Normal is less than 10 and more than 2 is basically indicative of highly restrictive filling. Prolonged deceleration time, that is the time taken from the peak filling velocity to the decline, and its marker of the stiff, slow to fill ventricle. Prolonged isovolumetric relaxation time, the gap between the closure of the aortic valve and the opening of the mitral valve. And in the diastolic dysfunction, it is high. And the other supportive criteria were prolongation of the QTC, which it can be by the other drugs, so it was abandoned in the 2019 criteria, and last left ventricular atrium and the biomarkers. So there was a diagnostic shift from the 2005 to the modern criteria, which was basically dependent upon the tissue Doppler imaging and the speckle tracking echo, and the key metric was global longitudinal strain. This was the controversies which was surrounding the 2005 criteria, which was basically dependent upon the left ventricular ejection fraction, a decrease in SVR, an artificially inflated left ventricular ejection fraction, and approximately 40% of the cirrhotic had chronotropic incompetence, that is the beta blocker downregulation. Hence, they were not able to mount an effective response to the stress. So, there was a shift towards the resting echocardiographic assessment. There was an introduction of the subclinical systolic dysfunction via GLS, and there were more stringent diastolic dysfunction criteria which were used. There was a 2019 question defined as systolic and diastolic criteria, and coming on to the systolic criteria, left ejection fraction less than equal to 50%. And the main introduction was global longitudinal strain of less than equal to -18% was normal, and it was detected using the speckle trackled echographic. It basically are the longitudinal fibers in the subendocardium, and which is the area most susceptible to the ischemia and fibrosis. And there's a drop in GLS which is noted even before the drop in the left ejection fraction. The other criteria were diastolic criteria, and diastolic function basically now required 3 out of 4 parameter for the defining the diastolic dysfunction. Of most important of which was septal E velocity, and it is the actual velocity of the myocardial tissue relaxing. It is a marker of early diastolic dysfunction. It is more load independent and reflects the true tissue stiffness. E by E dash ratio. It is a non-invasive surrogate marker of left ventricular end diastolic pressure and the pulmonary capillary wedge pressure. It basically measures the ratio of the velocity of the mitral inflow versus the velocity across the mitral annular wall. Left atrial volume index, which is the volume of the left atrium at the end of the ventricular systole, and it is taken in measurement with the body surface area. It is also known as the HbA1c of the heart, and more than 34 is the cutoff, and it is a chronotropic marker of the chronic cumulative diastolic wall stress rather than the snapshot of the today's fluid status. That it basically indicates the chronic diastolic pressure overload. Then the tricuspid regurgitation peak velocity, also a marker of backward failures. This basically shows how to interpret the various echo findings. If the septal velocity is low, it indicates left ventricular relaxation is slow. If there is increase in E dash ratio, it indicates high left ventricular filling pressure. That is, the left atrium has to push hard and the patient is prone to develop pulmonary edema. And this basically can be important while pushing the fluids or the albumin, which basically predispose to patient receiving albumin having flash pulmonary edema. Left ventricular volume index, it indicates long-standing elevated filling pressure, and it is an indicator of chronic diastolic dysfunction. Increased TR velocity, how the pressure is transmitted to the pulmonary circulation, and this basically is responsible for the symptoms such as dyspnea or post-transplant hypoxia risk. This shows the diagnostic algorithm for the diagnosis of the cirrhotic cardiomyopathy. First step is basically to exclude the other cardiopulmonary diseases. Step 2 is to assess the systolic function, whether the left ventricular ejection fraction less than 50% or global longitudinal strain is less than minus 18. Then comes to assess the diastolic dysfunction, which is basically left ventricular volume index, E dash, septal velocity, E dash velocity, or TR velocity. More than 3, we are confirmed with the diagnosis of cirrhotic cardiomyopathy. More than 2, it is indeterminate, and we can move towards stress echo or a cardiac MRI. This basically showed how moving from 2005 to 2019, this basically decreased the sensitivity, how the specificity was increased. There was E by A ratio was replaced by the tissue Doppler. There was non-specific QTC ratio was removed, and there was removal of the blunt stress response. This was a study by Span et al., which basically showed that the new criteria had better predictor of predicting the major adverse cardiovascular event post the liver transplant. However, it was not predicted by the 2005 criteria. Septal E dash is the most important single echo predictor of predicting the major adverse cardiac event post the transplant. I have discussed earlier how the new criteria affect the prevalence of the cirrhotic cardiomyopathy. There's a decrease in the diastolic dysfunction by new criteria from 70 to 30%. However, via the systolic dysfunction, there is an increase from 5 to 20%. This basically summarizes the difference between the old and the new criteria. The old criteria was more a functional circulatory change. New criteria is a true myocardial disease. Main abnormality in the old criteria was diastolic dysfunction. In new criteria, it is systolic dysfunction plus advanced diastolic dysfunction. It measures the left ventricular ejection fraction at less than 55% response to stress. However, the new criteria is based on more of systolic dysfunction, global longitudinal strain, which appears earlier than the decrease in the left ventricular ejection fraction. More of diastolic dysfunction criteria have been included. The QTC prolongation has been has been removed. Stress echo is not longer required for defining the cirrhotic cardiomyopathy. It is more specific, however, maybe less sensitive, and the prognostic value of the new criteria helps in predicting the post-TIPS and post-transplant cardiac event. Coming on to the clinical manifestation which are seen with the cirrhotic cardiomyopathy, it is usually asymptomatic up to 50% of the time. Fatigue and exercise intolerance are the most frequent reported symptomatic complaint. Dyspnea is highly prevalent. Peripheral edema, palpitation, and arrhythmia, or there is a risk of acute decompensation of the heart. Acute heart failure can be seen post-TIPS or post-transplant. These are the conventional biochemical or the electrophysiological marker which have been used for cirrhotic cardiomyopathy, namely NT-proBNP. NT-proBNP more than 295 has been suggestive. 295 has been suggestive of cirrhotic cardiomyopathy, and however, with renal dysfunction and the severity of ascites, there can be falsely high NT-proBNP in cirrhotic patients. Troponin I elevation up to 6 months post transplant can be highly sensitive to predict the post-transplant cardiovascular event. QT prolongation, however, has been removed in the new criteria, but QTC more than 47 has been associated with increased arrhythmia and the cardiovascular events. The association of anti-proBNP with the higher risk of cirrhotic cardiomyopathy. These are the conventional drugs which have been used for the cirrhotic cardiomyopathy, namely beta blocker. They decrease the sympathetic overactivity, decrease the heart rate and the portal pressure, and they help by reducing the hyperdynamic circulation, improving the left ventricular diastolic dysfunction, and decreasing the risk of variceal bleeding. ACE inhibitor, they decrease the RAS activation. They have some antifibrotic effect and decrease the afterload, and can be of therapeutic benefit in reducing the myocardial fibrosis and afterloads. Similarly, mineralocorticoid acts, they have some natriuretic and the antifibrotic effect, and can reduce sodium retention and may help in reducing the myocardial fibrosis. Coming on to the special scenarios which we will see with cirrhotic cardiomyopathy, namely TIPS, transplant, and ACLF. So TIPS, as we know, can be emergency or elective in refractory ascites or bleed. With TIPS placement, there is shunting of there is shunt of the blood to the heart, and this splanchnic blood bypasses the liver, and there is an increase in the venous return of the right atrium. There's an increase in the cardiac preload, workload, and there's an acute hemodynamic stress on the heart. How the normal heart rate will respond? There is an increased beta adrenergic response. There is an increased contractility, increased stroke volume, and which help in maintaining the blood pressure. However, with cirrhotic heart, there's a blunted response to the beta adrenergic. There's impaired contractile reserve. There is inadequate cardiac output, and there is an increased left ventricular filling pressure, which increases the backward pressure to the lung, increases the risk of lung congestion and edema. There is forward failure of the kidneys, that is by the decreased renal perfusion, which can cause more of AKI, persistence of ascites, and increased mortality. A ratio of less than 1 post 28 days of TIPS has been associated with lower survival rate. They have been reported in 2 studies. And preoperatively, E by A more than 2 indicates grade 3 diastolic dysfunction, and TIPS is usually contraindicated. E dash more than 15 is indicative of more of left ventricular elevated diastolic pressure. The TIPS is contraindicated, and enlarged left atrium, that is the size of the left atrium at the end of the ventricular systole by body surface area more than 34, and E dash ratio of more than equal to 11 is a red flag for TIPS. So coming on to transplant and cirrhotic cardiomyopathy, during transplant there are 3 phases. One is the clamping of the inferior vena cava and portal vein, which slashes the venous return. And the empty heart is not able to mount a compensatory tachycardia due to the beta receptor downregulation, and there's severe intermediate intraoperative hypotension. Then comes the phase of reperfusion. There's unclamping leading to a sudden unleash of wave of cold acidotic blood into the heart, and the stiff fibrotic heart may not be able to distend to accept the volume surge, and it may basically cause instant diastolic collapse and acute right-sided heart failure and post-perfusion syndrome. Then the new liver phase, the new liver is able to clear the vasodilator, abruptly spiking the systemic vascular resistance, and the weak heart, which is usually accustomed to low systemic vascular resistance, is is failing against this sudden increase in the afterload, which basically may lead to the venous congestion of the new graft. So this basically predisposes to the increase in the post-operative and the perioperative cardiovascular mortality. How this CCM responds to the post-transplant. There's two components, which is one is reversible, which can be seen in up to 40 to 60% of the patient, and there's a reversible component of the systolic reserve and the electrical and the vascular mechanism, and the hyperdynamic state resolves, and there is normalization of the prolonged QTC. And the beta blocker, the receptor, they recover and restoring the normal heart response to the stress. However, the structural fibrosis, which was present pre-transplant, it remains, and it causes a permanent damage, and the stiff ventricle may not be able to fully relax. And then drugs and the metabolic syndrome post transplant may attribute to more cardiovascular mortality. The reversibility of cirrhotic cardiomyopathy can be seen in up to 34 to 57% of the patients. The cardiovascular mortality, they account for 7 to 21% of the post-transplant death, and the removal of the cirrhotic liver, it eliminates the toxic metabolites. However, surgery is itself the ultimate stressor for this liver. So coming on to how the phenotype is changing from the chronic to the acute for cirrhotic cardiomyopathy. There's we see ACLF very commonly. It is characterized by the cytokine storm, which is and profound systemic inflammatory response syndrome. There's a massive release of PAMs, DAMs, leading to surge of the inflammatory cytokines. There's acute myocardial depression secondary to the cytokine storm, leading to beta receptor downregulation and suppressing the contractile reserve of the heart. There's profound vasoplegia. This basically poses to type 1 cardiorenal syndrome, resistance to the vasopressor, and there's explosion of the biomarker, which is seen in the ACLF patient. The anti-proBNP and troponins can be very high. This has the clinical consequences of acute hypoperfusion of the kidneys, and despite having high doses of norepinephrine or terlipressin, we are not able to adequately generate the mean arterial pressure. This basically shows in how in cirrhotic cardiomyopathy and ACLF the standard isocare fail. The left liver is not able to, the heart is not able to push the blood, and we push the albumin, leading to for the acute kidney injury or any other indication, and it may predispose to flash pulmonary edema. Pushing terlipressin or norepinephrine may not be able to raise the blood pressure, causing the acute pump failure, and then we have to use the pump, basically inotropes such as dobutamine to help the pump. And there can be switching to the dynamic monitoring, such as POCUS and venous exploration ultrasound, which may help in better predicting the portal and the venous congestion in the renal blood flow and stopping the blood flow before the lungs flood. This basically shows how the chronic and the acute cardiomyopathy differs. The conventional is basically is a chronic cirrhotic cardiomyopathy. However, we can see acute on chronic liver failure associated acute cardiomyopathy. The prime driver in the chronic one is the fat inflammation, insulin resistance. It is usually outpatient and characterized by the increased stiffness of the heart and the vascular channels. In ACLF, it is acute. There's surge of inflammatory cytokines, usually seen in ICU, and can cause acute severe vasoplegia. It is fibrosis, irreversible, slow. It is acute, potentially reversible. In EMA, there can be thickened epicardial fat, which can be seen. There is in ACLF, there is acute drop in global longitudinal strain or left ventricular ejection fraction. There can be systolic failure. The biomarkers usually are galactin 3 and FGF21. In the acute, the inflammatory marker or troponins can be used as the biomarkers. So coming on how to work up a patient pre-transplant. Coming on to the algorithmic approach, how to screen a patient for a liver transplant. The phase 1 is initial screening and triage. Universal baseline is basically to have a detailed history, physical examination at lead ECG, echo, identifying the risk factor, namely age more than equal to 50, male, diabetes, MASH, other comorbidities. If there's zero risk factor, we may proceed to listing, more than equal to proceed to phase 2. Then cirrhotic cardiomyopathy protocol echo, evaluating the global longitudinal strain or the diastolic dysfunction. If it is less than 18% or severe diastolic dysfunction is present, high intraoperative risk halt. See if it is inconclusive, we may go for conventional CT, conventional coronary angiography, calcium scoring. The calcium scoring more than 400, we should refer the patient for invasive angiography. If DSC is used and it is unconventional, we should proceed to CPET or the CT angiography. Pathway B can be to basically measure the stamina, which can be with the help of a 6-minute walk test. Less than 250 is usually indicative of severe frailty, mandate prehabilitation and CPET, and more than 400 is indicative of good reserve. CPET testing can help in basically deciding the patient the stamina or the stamina of the patient. VO2 less than 11 ml per kg per minute is usually very poor, and patient should be halted and prohibitive risk for the liver transplant. More than 15 we should clear for transplant. These are the various variables which are used for the pre-transplant cardiac scoring. Global longitudinal strain, left ventricular ejection fraction EE dash, left atrial volume index, biomarkers such as anti-proBNP and high sensitivity troponin QTC interval, MELT score, right ventricular dysfunction, and age. And this is the scoring, which and score more than 7 based on these is indicative of high probability of post-reperfusion syndrome. DSC we commonly use here. It has advantages and some limitations. So I'll just mention in brief. DSC unmasks the contractile reserve, identifies the blunt systolic response, which is hidden by the low afterload at rest. It is very important in judging the dynamic obstruction, that is the latent left ventricular outflow tract obstruction or the systolic anterior motion. It can simulate the stress of the surgery, mimicking the sudden sympathetic surge and the catecholamine surge. It is renal safe. However, it is poor in identifying the CAD. In 40% of our patient can have chronotropic incompetence, and they are already hyperdynamics, may have ceiling effect, so it may not offer any additional squeeze. And there is a high risk of torsade pointes or in patient with baseline QT prolongation. So when the DSC is inconclusive, if you're suspecting So coronary artery disease, proceed for CT angio or invasive angio. If you want to check the contractile reserve, global longitudinal strain, surgical endurance, cardiopulmonary exercise tolerance, volume tolerance, site heart catheterization, and boluses of fluid to measure the left atrial volume index. So coming on to the new therapeutics, the new therapeutics which are used in cirrhotic cardiomyopathy, drugs such as ivabradine, which is a selective IF channel blocker, reducing the heart rate without affecting the contractility. Then there are antioxidant mitochondrial stabilizer, reducing the bile acid induced oxidative stress. So taurine, albumin may help as an endothelial stabilizer, binding the pro-inflammatory ligands. FXR agonist may help in modulating the bile acid signaling to reduce the myocardial damage, and modulation of the gut biota and improving the cirrhosis dysbiosis ratio and the gut barrier integrity may help in making the cirrhotic cardiomyopathy better. New biomarkers such as galectin, ST-T2, MIR155P, and lipopolysaccharides may help in identifying the patient earlier. And then there can be AI-driven prediction of CCM. There is a recent paper which was published on the ECG of the decompensated versus a compensated cirrhotic, which help in predicting the further decompensation with the area under the curve of 0.93. Then there can be automated GLS algorithm which may help in identifying the patient earlier. And there can be predictive modeling by feeding the 2019 criteria biomarkers and the inflammatory cytokines into the neural network. So and I'll just finish off with mentioning the limitation of the 2019 criteria. It basically focuses on the left ventricular mechanic. However, there should be an inclusion of the right ventricular free wall strain. There can be inclusion of the cardiac magnetic resonance, and which may help in quantifying the fibrosis and the extracellular volume. It is basically a static resting echocardiogram, including of the dynamic assessment such as passive leg rest coupled with echo may help in identifying the patient handling of stress better. Introduction of galectin-3, SST2, FGM, another fibrotic marker, and a nephritic peptide into algorithm. AI-driven approaches and identifying the different phenotype may help, and the introduction of the drug based on the phenotype of the cirrhotic cardiomyopathy may help in helping the cirrhotic cardiomyopathy patient. These are the various trials which are currently running on cirrhotic cardiomyopathy. One is carvedilol versus simvastatin, carvedilol plus ivabradine, GLP-1 receptor agonist, SGLT2 inhibitor, and the POCUS-based resuscitation versus standard care in patient who present with ICU and shock in fluid management. So to conclude, initially it was to recognize the abnormal circulation, present is to diagnose the systolic and the myocardial dysfunction, and the future is to predict and prevent the heart failure. Thank you.